All right. Well, thanks, Lauren, and thanks everyone again for hopping on. I'm going to talk to you today about oncologic emergencies as they might show up in the primary care setting. I know we have a diverse group of people here, and I do want this to be engaging and interactive. So don't hesitate to interrupt or raise your hand if you have a question or if there's something you want to talk about. We'll go ahead and get started because there's a lot to cover. I tried to focus on things that I think are more common or things that I've personally experienced just in my own career history when it comes to patients with oncologic emergencies. Just to get started, cancer is very common, and you are going to definitely run into patients who either have an established cancer diagnosis or somebody who doesn't have an established cancer diagnosis, but who's the initial touch point from the PCP perspective for where these patients present, because we're consultants, we're the people who you refer to. So the first touch point for the healthcare system for these patients with newly diagnosed cancer is usually the PCP or in the emergency room. And since cancer is expected to affect nearly 19 million people by this year, it's important to understand how these patients might present in your office and when to be concerned and when to engage your neighborhood friendly hematologic oncologist. Um, there are quite a few oncologic emergencies out there, but they can be broadly broken down into metabolic, hematologic, and structural emergencies, as well as treatment-related emergencies as a result of the whatever the patient is receiving in the way of chemotherapy, radiation, or surgery. So we'll just jump right in with a case. This is actually based on a real patient I saw, and this is called the case of the never-ending flu. And I had to throw this in here just because of my background. But anyway, there was a 22-year-old college kid who is visiting his primary care doctor, reporting ongoing fatigue and flu-like symptoms for 2 weeks that have been unresponsive to antibiotics. He's healthy otherwise, doesn't take any medications regularly, and hasn't been around sick people.
Hey Tina, if you're
Yes.
in your slides, we can't see them. We're still on the first slide.
Oh, I'm advancing them. Hmm. Are you seeing them move now?
We are not.
No.
No.
Hmm.
I can share
That
for
is, I'm sorry.
me to share for you.
Yes, why don't you go ahead and do that? I'll stop sharing. Sorry about that, guys. Thank you. The never-ending flu. I think you guys remember this is just a college kid who otherwise has no other issues and is presenting with influenza-like symptoms for 2 weeks and comes to his PCP's office. Next slide. And he is not looking extremely sick, but he also doesn't look well on physical exams. So you can see his vital signs here. He has a fever, he tachycardia, he is satting 89% on room air. He looks tired and pale, and that pallor is just kind of fairly obvious to the PCP. He's tachycardic, has scattered bibasilar crackles and mild conversational dyspnea, and he also has scattered petechiae on both arms and legs. Next slide. So as the PCP, you go ahead and order some blood work, and these are the labs that come back shortly thereafter. So his white blood cell count is 150,000. His hemoglobin is 5.7. His platelets are 35. Here are some notable electrolyte abnormalities here, particularly his BUN of 50 and his creatinine of 3.5. Next slide. So this is the interactive part of our talk, but if this gentleman was in your office, what would you do? Would you send him home and arrange for, okay, excellent. We have someone saying the ER. Um, and that's from Joe. So any other place would you send him home? The ER? Any other thoughts as to where you would go and why? Like, what is concerning about his presentation?
I agree with the ER because he's his counts are too out of whack to send him home and wait for him to see a hematologist in a week or something like that. I think he needs immediate attention.
Yep. Thanks, Laurie. Any other thoughts? Okay, next slide. So I would agree with the ER as well. This in this young patient with those labs, I think there is reason to be suspicious for an acute leukemia. While that patient is in the PCP's office and waiting to go to the ER, a few other things that a primary care physician could do in these suspected leukemia diagnoses that I don't always see is they don't always get a differential on the white blood cell count. They will just get the CBC without the differential. And so that will be important and may identify the presence of circulating blasts or other abnormal cells. Um, because of the patient's abnormal kidney function, you'll recall that he had an elevated BUN and creatinine. It'll be important to make sure that he doesn't have tumor lysis syndrome. And so things like a uric acid, LDH, and phosphorus are important, particularly in patients where you're thinking about acute leukemia. Coags are important. They're frequently missed. I know from just my standpoint, when I used to get these patients transferred into me, there was usually no coags on these patients. And the reason those are important is to rule out DIC, which you can see in acute leukemias and in a specific type of leukemia called acute promyelocytic leukemia, which I was told by someone is the most common reason why hematologists get sued for not failing to recognize that promptly, because those patients can have catastrophic bleeding complications and die pretty quickly. So, this particular patient has multiple issues that could lead to death. One of them is his really elevated white blood cell count and possible symptoms of leukostasis. I gave you some hints about that because he was having some difficulty breathing. People who have leukemia have an excess of leukemia cells, which we call blasts, that tend to be sticky and clog up the smaller capillaries and blood vessels, and they can lead to things like difficulty breathing, headaches, and so that's important to keep track of because they can be treated with leukapheresis. And then we think he has tumor lysis syndrome on the basis of his increased creatinine and he had really significant anemia and thrombocytopenia. And so I would definitely agree. I don't think many people would miss this. In my career, I've seen one person do this, where the patient presented to the PCP's office similar to this and actually went home. But most people definitely know well enough to send patients with a suspected diagnosis of acute leukemia and tumor lysis syndrome straight to the ER. I do recommend a verbal communication to the ER, physician or the charge nurse, because sometimes you don't know how these patients are going to get triaged once they officially go into the ER. And I can tell you that when I was a fellow at the University of Maryland, one of the APPs I worked with, her daughter came to the ER with similar symptoms like this, but had a white count of 350,000 and was a new diagnosis of acute promyelocytic leukemia. She passed away in the ER, basically waiting to be seen. And so I think that if you are seeing these patients at any other point in their care outside of a hem-onc office, talking to the ER so that they don't get triaged. And sometimes they look sick, but they don't look as that sick. And so sometimes they don't get triaged accordingly, and that can be really detrimental to the patient. Next slide. So, one of the oncologic emergencies that was highlighted in this case, and we've talked about, is tumor lysis syndrome. Tumor lysis syndrome happens pretty commonly in people who have certain hematologic and oncologic malignancies. We see them a lot in leukemias, we see them in lymphomas, especially. And they can potentially lead to death as a result of renal failure or cardiac arrhythmias, if they are not promptly recognized. And so tumor lysis syndrome can happen spontaneously, or it can happen secondary to treatment. So some people can present in tumor lysis, and some people develop tumor lysis shortly after they develop chemotherapy. So it's important to be on the lookout for particularly leukemias and lymphomas to ensure that this is not happening, because it's easy to identify if you know to look for it, and it's also reversible as well. Next slide. So tumor lysis syndrome happens because basically the tumor burden is so high in the spontaneous cases that the cells sort of spontaneously break apart and they release their intracellular contents into the blood, which include uric acid, potassium phosphate, and other chemicals. And the uric acid is a particular problem because it can lead to renal failure. And I have seen patients end up on dialysis because of this as well. The elevated potassium too can lead to cardiac arrhythmias, which are potentially life-threatening. Same with the release of phosphate. It can combine with calcium to form crystals, which can deposit in various tissues and organs. And so overall, it's caused by the breakdown of the tumor cells themselves, and all of one of my fellows used to call this as the tumor cells, quote, spilling their guts into the bloodstream. And that really is what's happening. I mean, they're releasing all of this stuff that can be very catastrophic for the patient. Next slide. Risk factors for tumor lysis syndrome. So, as I said, we talked a little bit about the heme malignancies that are at risk for this, mostly the acute leukemias and the aggressive lymphomas, like diffuse large B-cell lymphoma, can do this as well. Patients who have a really high tumor burden, at baseline when they start receiving treatment can develop this as well. Patients that have pre-existing kidney damage are also at risk. And the nature of the chemotherapy drugs can also cause tumor lysis syndrome. One drug that I like to call attention to because it is used in a lot of heme malignancies is a pill called venetoclax, or Venclexta is the trade name. It is used for the treatment of a lot of hematologic malignancies, and in and of itself places patients at risk for tumor lysis syndrome, particularly in chronic lymphocytic leukemia. So I think understanding that this can happen in certain types of diseases is really important in order to know to even look for tumor lysis. Next slide. The main things you're going to want to look for are kidney function, so BUN, creatinine, uric acid, LDH, phosphorus, and calcium are the main things that you want to look for on the tumor lysis labs. I often see them overlooked. And then just keeping an eye on the patient as well, making sure that the EKG looks okay, that they are mentating well. So when you sort of marry the two together, it's actually fairly straightforward, this diagnosis. Next slide. In some patients who we know are at risk for this, we often treat them with fluids up front, as well as something to lower their uric acid, whether it's allopurinol or rasburicase. And so that can help lessen the damage from that high uric acid that we see in tumor lysis syndrome. Next slide. And so when these patients present, they are managed pretty aggressively. So with fluids, correction of their electrolyte abnormalities so that you can prevent secondary complications as a result of that. There are a handful of patients who sometimes temporarily require dialysis in order to get rid of all of those contents that have spilled into the bloodstream as well. And then as we talked about, allopurinol and other uric acid lowering agents can help to mitigate the risk of this disease as well. Next slide. So that's case number one. I sort of spent a lot of time on that because I'm biased towards heme malignancies. But anyway, we'll move on to our second case, and this is Peter M. He has been wobbly for a week. He's a 65-year-old retired engineer who comes into the PCP's office with fatigue, nausea, and confusion over the past week. Next slide. And he says that this has been going on for about a week. He's had increased thirst, frequent urination, and constipation. He's lost 10 pounds in the past month. He does have a known diagnosis of non-small cell lung cancer, which was diagnosed 2 years ago and was treated with chemotherapy and radiation. Next slide. And he himself is a non-smoker. He quit 10 years ago. On physical exam, I mean, he doesn't look super sick, but he looks tired. He's visibly very dry. And he seems, his wife is with him and reports confusion and lethargy. Next slide. Okay. And so, and this is corroborated too on the physical exam. Importantly, people who have this particular type of complication, they don't all, it doesn't always scream emergency to you. I mean, the vital signs for this patient actually looks okay. And really, aside from being kind of dry and confused, he doesn't look too bad. Next slide. So you end up getting labs on him and see that his calcium is 13.5, and the rest of his labs, or there's corrected, is actually 14.1. The corrected calcium takes into account the patient's albumin as well. His parathyroid hormone is low, and his parathyroid hormone related peptide is elevated. His creatinine and phosphate are within normal limits, but just barely. His chest X-ray shows no new lesions, and he has a stable appearance of a known lung mass. And his bone scan shows no new bone metastases. Next slide. So this patient demonstrates another emergency, which is hypercalcemia of malignancy, and it happens in about 10 to 30% of patients with cancer, although there are some cancers that are more at risk than others, such as multiple myeloma and breast cancer. Pretty much any cancer that has spread to the bones can do this. The symptoms, I actually see this we end up admitting a lot of patients from our clinic with this, but they oftentimes don't have any symptoms. If they do, then the degree of hypercalcemia really is very significant. But things that the patient might present with include confusion, or cognitive issues, constipation, nausea, vomiting, and symptoms of dehydration. This is definitely something that needs to come to the emergency room, and the patient needs to be admitted for prompt stabilization and improvement of their calcium levels. And the mainstay of treatment for hypercalcemia of malignancy is usually IV fluids, although you can give bisphosphonates such as Zometa, or denosumab, which is a rank L inhibitor, to lower serum calcium levels as well. And so, unfortunately, prognosis isn't always great in hypercalcemia of malignancy. There's a median survival of 35 days from the time of diagnosis if this occurs. Next slide. Risk factors include certain types of cancer, breast, lung, and kidney cancer, as well as myeloma, and how advanced the cancer is, and the presence of bone metastases. So it's something that you should consider in somebody who has those types of malignancies and evidence of bone disease as well. Next slide. And we talked a little bit about like the causes. So, in the setting of bone metastases, when the cancer cells actually are in the bones themselves, they can cause increased bone resorption and release of calcium into the bloodstream. So, essentially, the bone is being broken down itself, and the calcium exits the bone and goes into the bloodstream itself. In some patients, you see increased production of parathyroid hormone related protein, which looks like parathyroid hormone itself. It's a paraneoplastic effect, and it can cause calcium to be increased in the blood. Other cancers cause increased production of vitamin D. So cancers like lymphomas can increase the production of the active form of vitamin D, which leads to enhanced intestinal absorption of calcium and increased blood calcium levels. Next slide. The actual diagnosis of hypercalcemia of malignancy is fairly easy to make because if they have an elevated calcium level and really no other reasons to explain it other than their malignancy, then that's kind of what you're left with. A lot of people don't always check parathyroid hormone related peptide, but that is an important thing to check and it is available in pretty much any lab. It tends to be elevated in hypercalcemia of malignancy and is a driver of excessive calcium release from the bones. Um, and then, depending on the context in which you're seeing the patient, certain imaging tests can be used to help determine if they're in patients who don't have an established diagnosis of cancer, whether or not that's something that could be driving it. A new diagnosis of cancer, in other words. So the mainstay of treatment is fluids, 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 sometimes diuretics as well to lower calcium levels. In patients who are not responding to fluids, we will fold in bisphosphonates to help reduce the calcium level as well. Very rarely do we use calcitonin. It works really quickly, but it has its own side effects associated with it. So I don't typically reach for it unless we have a patient who's really refractory to fluids, diuretics, and bisphosphonates. And of course, treatment of the underlying cancer should prevent future recurrences of hypercalcemia of malignancy. Next slide. Generally, in order to prevent this from happening again, it's important, and we do this in oncology as well, but just keeping track of those calcium levels regularly, making sure that the patients are good about drinking their fluids. This can be an issue for patients who are actively on treatment for cancer because they don't always feel good. Sometimes they're very sleepy and they forget to drink and to hydrate themselves, and that can subsequently lead to an increased calcium level as well. And then the other thing that a lot of folks forget is medicines that can also exacerbate hypercalcemia. So certain diuretics, vitamin D supplements, and antacids can increase calcium levels as well. So if there's a patient who's at risk for this, it's important to do a comprehensive medication check and make sure that there's not other things that can potentially worsen this symptom. Next slide. So, we talked about how, we talked about two of the three of these, but in the world of cancer emergencies, so tumor lysis syndrome and hypercalcemia of malignancy are two really common metabolic emergencies that may come to a PCP's office. There's also syndrome of inappropriate ADH, a syndrome of inappropriate ADH or SIADH, which we can see with certain cancers as well. And so typically we see it in small cell lung cancer and with certain chemotherapy agents as well. So it should be someone who, it's something worth suspecting if you are seeing somebody who either has cancer or who you suspect has cancer who presents with a low sodium. Next slide. And hematologic malignancies are sort of the other category of emergencies that can present to a PCP's office. Of these, the most common is definitely febrile neutropenia. And so febrile neutropenia is defined as a temperature of 100.4 degrees Fahrenheit or 38 degrees centigrade in a patient with a neutrophil count under 500. And febrile neutropenia is definitely an emergency, and it's an automatic admission or presentation to the ER because these patients don't have the immune system to combat infections, and so they do need to be on broad spectrum antibiotics to make sure that any life-threatening infection is being addressed. So that is just something worth knowing. And hyperviscosity syndrome is basically a condition in which the blood is too thick as a result of some type of blood cancer process. The most famous example of hyperviscosity syndrome tends to happen in patients who have Waldenstrom's macroglobulinemia, which has now been renamed, I guess, to lymphoplasmacytic lymphoma. And basically, these patients have really thick blood as a result of the IgM protein, and they can present with sluggishness, strokes, neurologic issues. And so plasmapheresis and chemotherapy is important to help make that blood less thick. We also see hyperviscosity, as I'll put in another plug, in acute leukemias, where there is a really elevated white blood cell count. And so typically those patients can also the tricky thing with a new leukemia diagnosis, and we saw this in the first case, is that the patients can have a really high white blood cell count, but they're also profoundly anemic. So then there's some discussion over whether or not you even give them a blood transfusion, because you could potentially worsen that, the thickness of their blood as well. But just something to be aware of in patients who have an underlying blood issue. Next slide. We talked quite a bit about febrile neutropenia. This is one of the most common reasons why people present to the ER, and it's one of the most common reasons why patients are in the hospital when they're on chemotherapy. So just keep track of their temperature and their neutrophil count, and that will officially make the diagnosis. And the important thing with patients with febrile neutropenia is that they require broad spectrum antibiotics. You can't be, at least at the outset, you can't treat them with anything more narrow in terms of coverage, because you don't really know what they're struggling with. Next slide. And hyperviscosity we talked about as well. And also with respect to Waldenstrom's and leukemia and multiple myeloma, the PCP needs to think about this in case you have a patient in the clinic with leukemia, myeloma, or suspected leukemia, myeloma, who has like new onset confusion, or sluggishness or something that would make you think that their blood is a little bit too thick. Next slide. So this is another patient. This is case 3. We've talked about the metabolic emergencies as well as some of the hematologic emergencies so far. And now we're going to move a little bit into structural emergencies. So this is the case of Jacob L. Jacob is a 65-year-old guy who was diagnosed with spinal cord compression due to metastatic lung cancer. He's a retired software engineer who enjoys hiking and spending time with his grandkids. He's been a lifelong non-smoker, and this diagnosis has come as a surprise to him and his family. Next slide. So cord compression, I think we all know what it is. We just don't want to miss it if we see a patient walking in with these symptoms. So spinal cord compression happens when the cord itself is when there's pressure on the spinal cord as a result of cancer, or some other process, but at least because this is a cancer echo, it's going to be either because of a mass or something impinging on the spinal cord itself. And so that pressure on the spine ends up causing a lot of pain, numbness, weakness, and possibly issues with coordination and bladder and bowel function. So it's important to ask about those things if you're seeing someone who presents with new onset back pain and lower extremity weakness. So if this is suspected, one of the first things we do, or we should consider, and it rarely harms anything, is we start patients on steroids in order to help decompress some of that pressure that might be on the spinal cord. Long term, those patients are usually managed either with radiation or with surgery, depending on the cause and the extent of the spinal cord compression that's there. It's really important to recognize this early, because if you don't, the patients can have permanent neurologic compromise and possibly never walk again or never regain bowel or bladder function. So just something to be aware of, that this is manageable if you catch it in time. It can be permanent if it's not caught in time. Next slide. So tumors and metastatic cancer can cause this, as well as compression fractures. I think a lot of people forget about that. For some of these cancers that spread to the bones, such as breast cancer or melanoma or lung cancer, if the patients have a compression fracture, that fracture in and of itself can cause cord compression, in addition to the actual mass that's sitting there on the cord. Next slide. And I can't emphasize this enough. So anybody walking into the PCP's office or the ER with back pain, numbness, weakness, or loss of bladder, bowel control needs an urgent evaluation, and spinal cord compression should be suspected, either whether or not they have a known cancer diagnosis or not. Next slide. In order to officially diagnose cord compression, the patients either need an MRI, a stat MRI, or a CT scan or a CT myelogram to have a better idea of how well or to actually see what's going on in the spine itself. So that will ultimately clinch your diagnosis and lead to the pathway to treatment. Next slide. So initially, I managed these patients with steroids, but then promptly the oncologist and the radiation oncologist, plus minus the neurosurgeon, all need to be involved in the management of these patients. Sometimes I do see turf wars between radiation and neurosurgery when it comes to management of the compressive mass, but I think in general, I would start with one or the other and determine what they will determine whether the patient is a candidate for either surgery or radiation. The one thing that often sort of I think gets forgotten is the pain management piece of this, because the pain is really, it can be really debilitating, and the pain associated with cord compression is going to impact our ability to adequately care for these patients, because some of these people cannot move, they cannot lie still for radiation therapy. And so making sure that the patients are on a comfortable regimen in terms of their pain control is really important. And I think sometimes there is a hesitancy that I know I see when I'm rounding on these patients to prescribe pain medications. But believe me, the pain is really a problem and it will impact their care. So it really is a cornerstone of their treatment as much as the steroids, the radiation therapy, and the surgery. Next slide. So we talked about cord compression. Other structural emergencies include superior vena cava or SVC syndrome and malignant pericardial effusions. So SVC syndrome, we normally see that in lung cancers and lymphoma, and essentially it's because of compression of the superior vena cava by the cancer itself or the lymphoma, and basically because of that compression, you end up having swelling and just a lot of local symptoms as a result of the pressure that the mass puts on the superior vena cava. And so this is also considered something that requires prompt treatment with steroids, radiation, possibly stenting, but it's something worth considering in somebody who seems to have a swollen face or a swollen limb. An X-ray or some additional studies can help identify whether or not there is a compressive mass on the SVC. And pericardial effusions as well. They happen in about 20 to 35% of cancer patients, especially in lung, esophageal, breast cancers, leukemia, lymphoma, and melanoma. Important to consider in patients who have, unstable vital signs, chest pain, a rub on exam. Typically, those patients are managed either with a window, a pericardial window, or a pericardiocentesis in order to alleviate those symptoms. Next slide. Moving on to treatment-related emergencies. So these are things that we can see in patients who are already on chemotherapy. And so sometimes it doesn't happen infrequently. Patients on chemotherapy can have an accidental extravasation of the chemotherapy agent into the surrounding tissues, and that can lead to that can actually be extremely painful. And so, depending on which chemotherapy leaked onto their skin, so there you can see skin changes, necrosis, swelling. Those are all things to be aware of in case somebody gets chemotherapy and then at some point presents to their PCP because they have some sort of a rash or pain in their arm or what have you. Typically, there are antidotes to certain chemotherapies that we can administer in case this happens, or depending on the extent of the damage, other specialists may need to be involved, like plastic surgery or dermatology. Other things, so GI problems are really common in patients undergoing cancer treatments, and the symptoms listed here, especially diarrhea, nausea, vomiting, more often than not, these patients call into the oncology department, but sometimes if for whatever reason they can see their PCP or someone else, these are important to keep note of, or in case they show up in the PCP's office, because they could be related to the chemotherapy itself, or the GI issues could be related to a secondary infection as a result of the chemotherapy. So these are good things to get your local oncologist involved in, but certainly they can also be seen in a PCP's office. Next slide. And our last case, I kind of threw this in here because of the way that cancer care is these days. So, case four is called Not Even on Chemo. And so, a 55-year-old patient with metastatic melanoma was treated with an anti-PD-1 immunotherapy called pembrolizumab, also known as Keytruda. I'm sure you guys have seen some of these commercials on on TV. It's been around for 10 years now. And after several cycles of treatment, the patient comes in with diarrhea and abdominal pain, which was diagnosed as immune-related colitis, which is a common and potentially life-threatening complication of immunotherapy. So, immunotherapies have more or less infiltrated the oncology space. And I think as a PCP, it's important you don't need to know the nitty-gritty details of what regimen the patient is receiving, but I think it is important to know whether or not they're on an immunotherapy. And usually the patients do know. And certainly within our own healthcare system, you can see it in the charts, whether or not they are on an immunotherapy. They usually end in the suffix MAB, which normally helps you identify whether or not the patient is receiving an immunotherapy. But these PD-1 inhibitors, especially, they are all over the place, and they are FDA approved for a number of cancers. And so as a result of that, you can see a lot of complications as a result of those treatments specifically. Next slide. The side effects that we see in association with these PD-1 inhibitors are called immune-related adverse events, or IRAEs, for short. And so basically, what happens here is the checkpoint inhibitors themselves, like pembrolizumab, as shown in the last case, they target checkpoint proteins on the immune cells and basically cause them to recognize and attack cancer cells. So they basically manipulate the patient's own immune system and the immune system of the cancer cells themselves in order to kill off those cells. And so the checkpoint inhibitors block the interaction between these checkpoint proteins and prevent the cancer cells from evading the immune system and allow T cells to mount an effective anti-tumor response. There are a lot of checkpoint inhibitors out there. As I mentioned earlier, if the patient mentions something or if you see something in their chart with any treatment ending in MAB, that's probably a checkpoint inhibitor. So they're important to know about. Next slide. The immune-related adverse events happen because of because you're targeting the immune system with these therapies. You can inadvertently cause the body to more or less attack itself. And these immune-related adverse events can affect any organ system. The most common ones that we see involve the skin, and the GI tract. However, you can see other organ systems being affected as well, including the endocrine system. We do see pneumonitis and lung toxicities as a result of as a result of checkpoint blockade, rheumatologic issues, neurologic issues, and cardiovascular complications as well. And so I think it's important to know about, because these patients can otherwise the symptoms that they present with are kind of easy to dismiss because they can be mild in most cases, but in some patients, they can be severe enough to warrant discontinuation of treatment altogether. And so, I think it's just important that if a patient who's on a checkpoint inhibitor presents to their PCP's office with a new symptom, to make sure that it's not related to that medication itself. But more often than not, these people will come to oncology. And depending on, I will say that while about 75% of patients who are on immune therapy have some type of immune related adverse event, most of the time those side effects are mild and manageable with supportive care or creams or what have you. In more serious cases, we have to go after the immune system more aggressively with steroids or other more heavy hitting drugs that sort of dampen that response. But just something to be aware of because these drugs are all over the place. Next slide. The reason we think immune-related adverse events happen is largely because of dysregulated T cell activation, and ultimately leading to something we called a cytokine storm as a result of these hyperactive T cells that lead to the overproduction of cytokines and inflammatory mediators that cause this inflammation and damage. And so immune checkpoint inhibitors disrupt the balance between the different types of T cells and impair the mechanisms that normally maintain the immune response and prevent autoimmunity. Next slide. It's not 100% clear why some people get these immune-related adverse events and while other people do not. But we do know that advanced age, particularly people over 65, have a higher risk of developing immune-related adverse events due to decreased immune system function and decreased tolerance to immune-related side effects. And the other thing is there are some cancers now that are only treated with immunotherapy. They're not treated with chemotherapy at all. And the classic example is malignant melanoma, where patients get two checkpoint inhibitors or two forms of immunotherapy. And so that can also increase the risk of developing these complications versus people who are receiving a single agent immunotherapy drug. Next slide. In terms of monitoring and diagnosis, for any patient who is about to start treatment on these drugs, we usually do just a history and physical exam. The most important thing that we take note of is whether or not the patient has a pre-existing autoimmune disorder. So lupus, rheumatoid arthritis, any condition in which they've previously received drugs that have targeted the immune system before. Typically, we don't treat patients with an underlying autoimmune disorder with immunotherapy. We generally check their TSH and just their chemistry panel to get a sense of what their baseline is as well. In the oncology clinic, we monitor their labs monthly prior to the receipt of the the immunotherapy drug. And any changes that we see, we are prepared to jump upon. Two recent issues I've seen have been thyroid problems. So patients who previously had a normal thyroid become very hypothyroid or hyperthyroid, but hypo has been the more common abnormality that I've seen in my own practice. And I also recently had a patient to suddenly develop vitiligo on pembrolizumab as well. And so he's being treated for that, but he's not happy because it's changed his appearance, and the creams that he's using to treat it are $2,500 a month. So some of these side effects are really, it can be a problem. As we talked about earlier, recognition of symptoms and at least just knowing that this class of medications can cause a broad array of side effects is important to early diagnosis and treatment. Prompt intervention is important and can vary depending on the severity of the adverse event. So creams or whatever the symptom is, we try to manage it conservatively at first, but depending on how severe it is, we may have to pull out the steroids or things like tocilizumab, which is an IL-6 inhibitor, to sort of help dampen that immune response. And also depending on which organ is involved, other specialists outside of oncology may also need to be recruited, like GI, pulmonology, are a couple that I can think of. Next slide. So, because this class of medications is kind of I think just as a community of physicians, it's important to establish a reporting system where, where within the hospital system itself to let the care team know about potential side effects that are related to this class of medications. Comprehensive patient education is really important so that the patients can feel empowered to report whatever symptoms they're experiencing. One thing I've noticed a lot in the West Virginia population is there's a lot of people who tend to either minimize or they don't tell you what's going on with them. And so it's important that they understand that what they have as a result of their immunotherapy can be really catastrophic if it's not caught in time. Collaborate with multidisciplinary teams, institutional guidelines to help manage immune-related adverse events, and providing ongoing training and education to any healthcare provider who is involved in the care of that patient, whether it's in the oncology clinic or elsewhere. Next slide. And this is just, I think, a reiteration of what I just said in the last slide. But as of now, there's a lot of attention being paid to things like personalized biomarker monitoring, basically trying to find blood tests that might show early evidence of immune-related adverse events. There's research being done to look at novel immunomodulatory therapies, and there's a lot of resources being dedicated to improve patient education and monitoring so that we don't have patients passing away from these complications. Next slide. And with that, I will close. So hopefully that provided, I mean, it's a lot of information, but I think broadly, you can think of a lot of these oncologic emergencies being categorized as either metabolic, structural, hematologic, treatment related, or related to an immunotherapy. And just prompt recognition of those symptoms, because, like I said, there's going to be a lot of people who are going to be diagnosed with cancer, and that's unfortunate. Or there's going to be patients who are actively receiving cancer treatment who also follow with their PCP. And sometimes, there's usually what I see happening is that these patients sort of get turfed to us, which they should, but there are things that you can do in the PCP's office to help work up these patients and help to make their transition of care smoother so that there's no unnecessary delays. So, with that, I thank you for your attention. We have 8 minutes left, and so I'm happy to answer any questions that you might have or share insights on other cases that you might have come across in your own practice. But otherwise, thank you very much for your time.
Hi, Dr. Bhatnagar. I do have a question for you about the immune-related adverse events. And my question is, for most patients, are those more short-term, and once you're able to provide, treatment for them, that they get better, or are some of these something that can potentially become a more chronic condition for the patient?
They can be a chronic condition. I mean, theoretically, when and this is something that is not clearly understood, but the immune-related adverse events, they patients can take different paths in terms of how they end up faring in the long run. So there are some patients who, you stop the the immunotherapy and whatever side effects they have resolve. You sort of have the second bucket of patients where the side effects from the immunotherapy linger well, like years after they received the immunotherapy. And I do have a few patients in my practice who are like that, particularly with some skin changes and some late autoimmune issues. In the literature, I read that the immune-related adverse events can happen as far as like 2 years after you finish the immunotherapy. So there's all sorts of, you don't know up front, and I think that's an area of research so that we can get a better sense of how these guys are going to do.
Thank you.
Anybody else have any questions for Dr. Bhatnagar?
And Lauren, I put the CME registration link in the chat. Again, I know we had someone who joined us after we started. So if you are wanting to get CME credit or nursing credit and have not done this CME registration for this particular echo, please fill that out. And then that way we can make sure that you get your credits.
Did you already put the link in?
I just put it in the chat. But Joe, I know that you've attended a previous one that you had registered for, so you are good. Once
Okay.
you do that registration once, that's all that's needed.
There. Thank you.
Right. Well, I'd like to thank you, Dr. Bhatnagar. I appreciate it. It was super informative. And I think that everyone learned something. So that's the goal, right? So
Just
uh
one thing, just one thing.
one thing, yeah. I learned a lot more than that, but I'm not a clinician like some of you are, so probably knew more than me going in. But yeah, so our next session, if you'd like to join us, is in October. It's October 22nd. We'll be talking about treating special considerations and treating transgender cancer patients. So if you'd like to join us, I can drop that link in the chat, but it'll also be in the follow-up email that will be sent to all of you. And yeah, so just thank you all again. Thank you again, Dr. Bhatnagar, and I hope you all have a great rest of your day.
Thank you.
Thank you.